Welcome to our roundtable. I'm Jamile Shammo, a hematologist from Northwestern University. And today we're going to be talking about treatment options, specifically focusing on patients with low-risk MDS in first-line setting. Today I am joined by a panel of experts, and I would like them to introduce themselves.
Hello, I am Melhem Solh from the bone marrow transplant at Northside Hospital, Atlanta, Georgia.
Hi, I'm Somedeb Ball from Vanderbilt University Medical Center in Nashville, Tennessee.
Hello, my name is Bart Scott. I'm from the Fred Hutchinson Cancer Center in Seattle, Washington.
Hi, I'm Palmisiano from Rutgers Cancer Institute.
And hello, I'm David Swoboda from Tampa General Cancer Institute.
And our goal today is to talk about how do they decide on what to choose in terms of treatment for patients who have MDS. What is their timing for initiation of therapy, and what is the sequence that they would utilize in this setting? Today, we're going to be discussing treatment options for low-risk MDS in particular, focusing on timing for initiation of therapy and choice of therapy as governed by certain parameters, perhaps transfusion need or other biological markers, etc. So as you are trying to choose between the erythroid therapies, and I think in follow-up to what you had just started saying in terms of treatment options, what goes in your mind, like when you want to decide between any certain types of erythroid therapy? Do you, I would imagine that you would think about the hemoglobin cutoff, when do you start, how transfusion dependent is your patient, and or even durability of all the drugs that we have available. So.
You know, before we even get to the treatment, I think the biggest clinical question that I have to deal with is, do they even need a treatment?
Yeah.
Right. Yes.
And not every low-risk patient needs to start therapy right away, and a watch and wait approach is appropriate for some of those individuals, depending on what their symptom burden is. Certainly if they're transfusion dependent, they need to be treated. That's kind of a no-brainer, but I think most of us would start treatment before they become transfusion dependent, and when they develop symptomatic anemia.
I couldn't agree more. I think that cutoff, and I'd be curious to hear other people and what they think, the cutoff as to at which time you would say, I need to initiate therapy at this point. I think that is changing, if I may say so.
Yeah, I mean, historically, if you look at it, I mean, I totally agree that some of these patients may not need treatment for a while, but if you look at studies, mechanistically, if the hemoglobin level drops below 9 or 10 sometimes, the cardiac remodeling starts, right? So it's not about only patient symptoms, we have to also think the burden on other organs and how that's going to impact the long-term survival. These are the patient population that are going to live probably without transformation to leukemia for several years. So, you know, the anemia burden is significant. It impacts symptoms. Several studies have shown that if it drops below 10, people tend to be more symptomatic across different settings. So, I mean, that's something I keep in mind a lot of times. I mean, I don't necessarily, to Dr. Scott's thoughts, that I don't necessarily wait till they become transfusion dependent to initiate therapy, because a lot of my patients are symptomatic before that, and that's impacting their quality of life, as well as background probably, you know, other organ dysfunctions are setting in. So probably, you know, this calls for action to initiate therapy early.
Sooner.
Yeah, I mean, to answer your question, as I mentioned, it's variable and patient dependent. I mean, most of us don't just have a fixed number where you initiate treatment at it. So some patients can tolerate a little bit of anemia more than others, but everybody agrees you don't wait till you're transfusion dependent. You have to try to act sooner than that.
Yeah, and there's data that's being actually presented this ASH to support early initiation when they looked at, you know, the commands data and now analyzing based on a higher and lower hemoglobin and early initiation of luspatercept and ESAs. You know, the response rates were much higher when people went early. And now the Elements trial is obviously currently accruing with the goal of trying to prove that in a, you know, large study. And, you know, kind of prove what we already think, which is early initiation before it gets to the point to a patient becoming transfusion independent will benefit that patient in the short and long term.
And I couldn't agree anymore. I think that it's very important to have clinical trial data in patients who are transfusion independent, because we all know if someone was transfusion, we already have a lot of trial data to fall back on. But if you're transfusion independent, does initiation of therapy help? And I think perhaps until we get long-term and perhaps mature data from those clinical trials and others, it's very interesting to sort of have a mindful of what anemia does to the organs. And there's actually even data I saw about impact on the cardiac risk, basically. So you're starting to talk about not only symptoms, not only transfusion dependence, but also end organ damage and what that means.
And I was just going to say, I think an issue with that data is that most of it is in transfusion dependent individuals. So if you're not transfusion dependent, does the severity of anemia affect long-term outcomes? I think that's a clinical question that's unknown, and I'm looking forward to the Elements trial to see what it shows, to see if there's a benefit. You know, there was a similar study with EPO where they gave EPO early, and there was not a benefit in that setting to give EPO earlier in regards to preventing transfusion support. So I think it's important to remember we need to see what the clinical trial data is before we broadly recommend that everybody start treatment earlier and earlier and earlier.
I agree.
And the concern is too, of course, what sequence we use these agents in, and if we are burning through lines of therapy perhaps too early. And I think that that's always the concern too. So that line is always a fine one.
It's interesting because the analysis from the COMMANDS trial by Santini, they looked at earlier initiation, but I'm not sure. I agree with Bart in that I don't know that hemoglobin below 8 or greater than 8 necessarily reflects early versus late. It just simply reflects severity of the disease.
Yeah, and
right?
these people are transfusion dependent to be eligible.
Yeah, some actually had hemoglobin below 9, and not all of them were transfusion. The majority were, you're right, but some had hemoglobin below 9. And I think from what they have looked at, and again, it's a subgroup analysis comparing those who have hemoglobin below 8. I mean, I think we all knew that from older literature that looked at erythropoiesis-stimulating agents, right? If you have someone who's heavily transfusion dependent, just simply the response rate to ESAs is likely to be very low, and this has been shown over and over in multiple clinical trials, including the COMMANDS trial. So I think if you ask me about trends in treating low-risk MDS, and perhaps this falls short, then recommending starting treatment when somebody's hemoglobin is above 10, because we don't have data on that, but I think I see the field moving in the direction of correcting anemia prior to getting to the point of transfusion dependence.
Yeah, one other point I would like to add that, Dr. Scott rightly brought up our experience about ESA, but there may be some drug-to-drug variation in the way they act in the microenvironment. We have seen that obviously it's lenalidomide, which we know is very active in del(5q) MDS. Syntroref study has shown that if we initiate an earlier dose sooner, we can prevent transfusion dependence down the line. So I don't know. I mean, I would be curious to see if luspatercept can achieve that in the subset of population. It's different drug, different population altogether.
Yeah, completely different mechanism of action, and the anti-inflammatory properties of luspatercept may have additional benefits that go beyond just improving the anemia.
Yes. Well, I'd like to thank the panel for a provocative discussion on the management of low-risk MDS. Thank you all for participating. Thank you. And thank you for joining us.
Thank you.
Thank you.
Thank you.